Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
We have a 7-year-old girl who's got a both bone forearm fracture. She was playing superheroes with her sister on the sofa, jumped off the end and fell onto her outstretched arm with an obvious deformity afterwards, with no break in the skin and no bleeding, according to mum. Brought in immediately by the parents and was seen in the department. She's otherwise fit and well, up to date with immunisation, lives with her parents and 2 sisters. It was closed. It was neurovascularly intact, and she was relatively comfortable, but there was an obvious deformity of the arm.
Just going back a step, the whole story sounds like it all adds up. We're not concerned about a non-accidental injury.
It was appropriate. The patient told me the same thing as the mum. She was brought
Stories add up.
Yeah.
And a timely presentation.
Yeah.
A note of injuries.
Yeah. The hand was pink, warm, well perfused with a pulse, moving all the fingers, all the nerves were intact clinically. My neurovascular check, I start by looking at the hand. Does it look pink? And then I feel whether it's warm and well perfused. I then move on to checking a capillary refill. So I press in the fingertip for 5 seconds and then let go and count the amount of seconds it takes for it to go pink again, and it should be less than 2 ideally. Then I'll feel, if possible, if it's not obstructed by a cast, for a radial pulse. So that's the vascular check. Next I'll move on to the sensory check. So I'll touch here, which is the anatomical snuff box, and that's the sensation to the radial nerve. Then I'll touch here, the border of the index finger, and that's the median nerve. And then I'll touch here, which is the border of the little finger, and that's supplied by the ulnar nerve. So that's sensation. Then finally I assess motor function. So I ask for a thumbs up, and that's extensor pollicis longus, and that's supplied by the radial nerve. Other radial nerve tests you can do are finger extensions, that's extensor digitorum, as well as wrist extension, which is the extensor carpi muscles. So next is the median nerve, that's specifically the anterior interosseous branch of it. So I ask them to make a perfect circle like this. So a perfect circle is testing the flexor pollicis longus muscle, which is this, which is the thumb IPJ flexion interphalangeal joint, and the flexor pollicis longus inserts into here, and that's supplied by the anterior interosseous nerve. And then this one as well, which is flexion of the index finger at the distal phalanx, which is the insertion of the flexor digitorum profundus muscle. So that combined makes a perfect circle. Often, if the AIN or median nerve is compromised, they'll do that. If that's not normal, they have to be able to make a perfect circle. And if you're not sure, you can test it to see whether they can resist that to stop you breaking the circle. So that's the median nerve. And then finally is the ulnar nerve, so the intrinsic muscles of the hand. The easiest one is, can they cross their fingers like that? If you're not sure or they're a kid, you can ask them to make a starfish. And another test you can do is to ask them to make a pair of scissors and try and chop off the end of your finger like that. So that's all intrinsic muscles of the hand. And then finally, can they straighten their fingers? Can they make a fist? That's just checking that there's no significant ischemia or compartment syndrome in the forearm. So if they had compromised compartments, that would either be very painful or they'd be unable to do it. So that's my neurovascular check. The skin was heavily bruised, especially at the apex, but it wasn't threatened. It was significantly deformed. You can see the soft tissue shadow, especially on the lateral. It's bent all the way back. Soft tissues were swollen, heavily bruised, but blanching. There was a tiny bit of puckering around the apex as well. When you see bruising and you think, is the skin threatened? And by threatened, I mean, is the bone about to poke through it? Then it can be useful to press down on the skin to see whether, when you release it, it goes white and then it refills with colour. Because that suggests if it does blanch, that the tissue's alive, and it has a healthy blood supply. Whereas if it doesn't blanch, you're worried that it might be devitalized.
Skin tones that you normally see in textbooks are normally sort of pink to white to pink. Picking up rashes and cellulitis, erythema in other skin tones is different.
There's all sorts of other ways that aren't colour dependent. The other thing is the quality of the skin. Is it intact? Is it moist and bleeding? And the other thing about this one is there's a spike of bone on the x-ray, and if you can not feel the spike of bone because it's well covered with a muscle layer, and it is on the flexor surface, so there's quite a lot of muscle around, then you can be much less concerned than if you actually can see a contour of a bone spike and actually feel it just subcutaneously. That means that that's probably going to burst through.
So she's in the emergency department. We're faced with this. What are our options?
When someone's got an injury like this, what we want to do is get things straight, and we do that to rest the soft tissues and prevent any more damage or any erosion of the bone through the skin. And so the quicker we do that, the better. And what we can do in ED is to give ketamine, which is a very strong dissociative anesthetic, and that will allow us to manipulate the bone with the child completely sedated. And it's very safe and well tolerated in children. And that'll let us see roughly that the arm's straight. The drawback of that is that there is a bit of risk in the sedation, and also we don't have access to x-ray when we're there. So we can try and make the arm as straight as possible, but also sometimes they will need a second manipulation if it's not acceptable for the definitive management. She had a background of autism, and so a ketamine sedation would be contraindicated in this patient.
I was just wondering, what are the other common contraindications for ketamine in children other than autism?
There's two ways of answering it. The one is the procedural things, i.e. have you got the sufficient staff, the right space, and then there's the patient factors. Now, some of it is to do with, very young children, this will not be good for. It's got to be a compliant child with parents who understand exactly what you're doing. Otherwise, it looks incongruous that you take a bent arm and you bend it back, and everyone winces because it does look a bit unusual. So you've got to have a family that are completely on side with it and understand the process and understand why and what you're going to do. You've got to have a particular fracture pattern that is likely to be managed successfully by doing this. So if you had an off-ended supracondylar fracture, the chances of actually managing that definitively by doing this would be very low. And it's almost, you're adding an unnecessary step. Whereas a forearm fracture with a sort of 45-degree bend, you'll be quite confident that you can actually definitively managing it. So calculating the likely success of this as a procedure against as just something that's temporizing it. And so all of those bits will go into the mix. It's something we're trying to do for the majority of patients, unless there's a very good reason not to.
The other thing that we have to remember is that the people who are doing the sedation are the emergency department doctors who are not anaesthetists. They're trained in airway skills. But if you think about any patient who, if there was a problem and they did require an intubation because they'd lost their airway, any patient who had respiratory problems or had a difficult cervical spine or who had any kind of mandibular or oropharyngeal or nasopharyngeal issues that might prevent them having a straightforward intubation, that would not be someone who would be safe to perform sedation in the emergency department, because you wouldn't have the backup to immediately rectify any possible issue that arose. And I think
I've got a list of contraindications from the Royal College of Emergency Medicines. I'll just give you a few. So if it's less than 12 months, if they've got an active respiratory infection or active asthma, an unstable airway, or severe psychological problems or cardiac disease, and then recent significant head injury as well. Those are the main ones. That's not an exhaustive list, but those are the main ones that I've picked out.
So it's a team-based decision, and as orthopedic surgeons, we go down to the emergency department. When we have this conversation about what's the risk-benefit profile here, is it going to be safe to sedate this patient? Because you don't want to end up in a situation where somebody gets worse because of something that you've instigated. And so patient safety comes first every time. Sedation in the emergency department is not an option. So she's going to have to go to theatre.
Yeah.
It's 9 o'clock at night. When did she last eat and drink?
Yeah, she just had dinner, unfortunately.
Right, so that puts us in a tricky situation. Whether we can go to theatre tonight, or does she wait until tomorrow morning?
I would want to definitely involve the consultant with this decision. I'd also have to check with the theatre coordinator that there's space in theatre and the personnel to do it, and also chat to the parents about the risks and benefits of both. Yeah, I would put on a back slab just as it is to give a bit of a support and give her analgesia. So you can't leave this in this position. It's not acceptable. So number one in my plan would be to go to theatre, anaesthetic, and try a closed reduction to try and get that straight. And then I'd put on an above elbow cast, have traction, someone else at the elbow with counter traction to pull it straight. And hopefully that would align things pretty well. And then you can just make sure on both planes that you make the adjustments as necessary. And hopefully it would be possible and that spike hasn't buttonholed through any soft tissue.
On the left side, we've got an AP. This is the radius here, and this is the ulna here. You can see the fracture there, and you can see the fracture coming through there and coming through there in the ulna. So it's a proximal ulnar fracture and a proximal radius fracture at the same level. Is that stable or unstable?
Unstable.
Because they're at the same level and both the bones are involved. But we've got an apex here. Now, when you're looking at a forearm, but looking at the wrist and then the hand, you know that this is the thumb. The big metacarpal there is the thumb. And so you know that's the volar side of the hand. So this is anterior here. So this is apex anterior.
Yeah, so if we couldn't get the position acceptable closed reduction, we'd have to open it, so make a cut at the fracture site to directly visualize the bone ends and remove any interposing soft tissue. And then we'd have to hold the bones in place with something. And I think the options here, you could use a flexible nail down the intramedullary canal, or you could fix it with a plate and screws. So the flexible nails, you can potentially put them in without opening up the fracture site. So you can preserve all that biology around there where you've got the bleeding, which will form a hematoma and eventually a callus. And you don't have to strip any of the soft tissue away.
That's what it was manipulated in the operating room. So that's reduced it, everything's back where it belongs. And so she ended up with a plaster. Can you talk about your options for plaster?
So you'd want an above elbow plaster here to control the rotation of the forearm. So after everything we do a neurovascular check, make sure we haven't trapped a nerve whilst we're reducing it, and check the pulse, make sure the hand is warm, well perfused. You've got a high energy both bone injury of the forearm, and they contain some quite tight compartments, so it wouldn't be impossible for this child to develop a compartment syndrome post-operatively. And the signs of that would be unrelenting pain on passive stretch of the fingers and thumb. So I'll be checking whether they can straighten out their fingers and make a fist without too much pain.
How often would a compartment syndrome occur in this type of fracture?
Percentages I can't give you, but in terms of risk of compartment syndrome, kids it's less likely, and the highest risk group would be a young muscular man, so age between 20 and 40, of the forearm compartments or the lower leg compartments. So they'd be the most likely. I think for the injury, relatively high risk, but from a patient point of view, relatively low risk.
Yeah, I think that's right. The incidence is very low, and it would be an extremely unusual occurrence, which makes it all the more dangerous because people don't look out for it. So if it's the one that's happening and it's in front of you, you have to spot it because the consequences are catastrophic. It will cause this limb to effectively lose useful function. So in answer to the question, it is something you always have to check for, but it is very unusual in a child for it to happen.
Yes, I'd want to keep this child in overnight, and then the next day I'd again assess the neurovascular status, make sure they can fully straighten their fingers and make a fist. And if they're able to do that, I'd be happy that there's no compartment syndrome, because it would otherwise be too painful and they'd be unable to do it. Yeah, so I think age is on her side, but it's a highly unstable injury. I would see her in a week and take repeat x-rays to make sure they haven't moved.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at the Grand Academy at btinternet.com.